Good evening, and I always do very short introductions. I don't know, probably too short. I'm Terry Lohman. I'm one of the co-chairs for Unitarian Universalists for a Just Economic Community. And we're here with Steffie Woolhandler from Boston, I assume, because you're work at Harvard, if I'm not mistaken. But
I'm in New York City right now, but I do work in Cambridge as well. Yeah.
Okay. You ready to take it away? She's got plenty to say, and I told her less is always good. So
that way we'll have more time for discussion and questions. So good. Okay. Yes, I'm Steffie Woolhandler. I don't have any financial conflicts of interest. I want to start with what's on this slide, which is maybe the most important thing to even know about health in the United States, was just how short our life expectancy is in the United States relative to countries that are a lot like us in a lot of ways. The United Kingdom, is Costa Rica. We think of as a poor country, but they're still living almost 4 years longer than we are. Germany, Canada's living almost 5 years longer than we are. Sweden's up there living 6 years longer. So,
it's on their screen.
Okay, somebody needs to turn on their mute their mic. We're hearing something in the background. Just look at your mic. So so in fact, we're doing very, very poorly in terms of health in this country. And of course, most folks, mostly that's driven by, that everybody's doing worse than they are in Europe. But even our longest lived population, Asians, don't do much better than people in Europe. And then Hispanics, whites, blacks, and particularly American Indians and Alaska Natives have life expectancy that's really quite short. So however bad we are on average, things are even worse for particularly our Black and Native American populations. And as everybody knows, those are the two populations that have been historically suppressed by what people call racial capitalism. That capitalism in the United States was based on the seizure of Native American lands and the labor of enslaved people. So stolen lands, stolen hands. And to this day, we're seeing these very low life expectancies in these two groups. Now we have desegregated the healthcare system, at least in a formal sense. This is actually Black physicians picketing the AMA meetings in the early 1960s. The AMA was actually segregated until 1968. Hospitals were segregated until 1966. And can you guys see the top part? I need to move that little button there. It's fine. Okay. Well, okay. All righty. So, formally we've been desegregated, and yet when we look at, this is doctor visits since 1963 to 2019, comparing the number of doctor visits that white Americans get with the number of doctor visits that Black Americans get, Blacks have always gotten fewer doctor visits despite being sicker. And you'll see that, the two curves are widening, that white people now are getting about 3 more doctor visits a year than Black people. So we're not distributing our healthcare in a way that corresponds to the need of these populations. Now, a lot that has to do with health insurance. We're all familiar with the fact that a lot of people in the United States are uninsured. This is the number of people who are uninsured all year, starting in 1940, if you will. And you'll see the number was fairly high until the passage of Medicare and Medicaid in the middle of the Civil Rights era. They were passed in 1965 and implemented in 1966. And right after that, this is the Johnson era, there was a big drop in the number of uninsured. However, the number of uninsured never dipped much below 20 million. There's always been, certainly in my entire lifetime, there's been at least 20 million uninsured Americans. And then that number really started to creep up until around the time of the passage of the Affordable Care Act in 2010. And we got another fall when the Affordable Care Act was fully implemented in 2014. That's that second big dip. But here we are, poking along with about 25, 26 million uninsured Americans, and it doesn't really seem to be getting much better. So that's part of the problem, that there's a lot of uninsured people. The other problem is that many people who have insurance now get their insurance through the Medicaid program, that a joint federal state program that pays for the poor. And Medicaid enrollment has been going up and up and up, and that's one of the big mechanisms the Affordable Care Act used to expand coverage beginning in 2014. And of course, Medicaid's a whole lot better than being uninsured. It's definitely a good thing. It beats being uninsured. However, Medicaid is not the same as other insurance. Medicaid does not give poor people full access to specialized services. And this is actually a great sort of secret shopper study where research assistants called up doctors' offices with a story, a made-up story about their child having gone to an emergency room the night before. The emergency room doctor said, "Oh, your child definitely needs to see a specialist in the next 2 weeks." And and then the secret shopper would say, either my child has Medicaid or my child has private insurance. And for instance, orthopedics has that second set of bars. They say, "Oh, my 10-year-old daughter has a broken arm and she has to see an orthopedist in the next 2 weeks. Can you see her? She has private insurance." 98% of the time you could get an appointment in the next 2 weeks. You tell them that kid has Medicaid, and only 20% of orthopedists would offer an appointment. Now, it's easy to pick on orthopedists, but it really wasn't that much better for anybody else, for psychiatrists or lung specialists or neurologists. If you have public insurance, you just can't get the same access to specialist care in the United States that people with private insurance or even Medicare are able to get. So yeah, people with Medicaid are insured, but they're underinsured. They don't really have full access to care. There's another sense in which people are uninsured, underinsured, even if they have coverage. Many people in the United States enter medical bankruptcy. In fact, it's one of the leading causes of personal bankruptcy, accounting for between half and 2/3 of all personal bankruptcies in the United States. And this is some work we did starting years ago with Elizabeth Warren while she was still not a senator. She was a Harvard professor. But looking at medical bankruptcy, and you're probably familiar with the main finding of that study, which was that there's a lot of medical bankruptcies in the United States, but you're probably less familiar with this finding, which was that the majority of people who entered medical bankruptcy had insurance, at least when they first got sick. And the most common scenario was people had private insurance, which they held on to throughout the bankrupting illness, but were bankrupted anyway by gaps in their coverage, like co-payments, deductibles, and uncovered services. So you can have health insurance, but still be stuck with thousands of dollars in out-of-pocket costs that can lead to bankruptcy. So of course, that's the other form of underinsurance. You have Medicaid, no one will take it, or you have private insurance, people will take it, but you've got these co-payments and deductibles that can bankrupt you. And the situation's getting worse. The average deductible, which is the amount of money you have to pay before your insurance even kicks in, for a worker with a large employer is already close to $1,800 deductible. And that's a lot of money for many working families. Situation gets even worse when we start talking about expensive medications. This is some work we published a couple months ago in Annals of Internal Medicine, where we found that about 1.3 million Americans are rationing their insulin. And many of these people have insurance, but the insulin is still so expensive that they ration it. They try to use less and skip an insulin shot. They delay buying it even when they need it. So, people without insulin can die. And people who are diabetic and need insulin can die if they don't use their insulin, and yet 1.3 million Americans are forced to do so because the insulin is so expensive for them. Okay. When people are uninsured or underinsured, they delay seeking care for heart attack. So I think most people probably know that when you, when you get heart attack symptoms, a heaviness in your chest, you're really supposed to rush to the hospital or to at least call your doctor, because if it's a heart attack, you need to get, drugs that'll break up the clots, or a catheter shoved in there to break up the clots that are blocking the blood flow to your heart. So a lot of people know you're not supposed to delay care if you have symptoms of a heart attack. But it turns out if you're uninsured, all the way on the far right, you're 38% more likely to delay care when you have heart attack symptoms. But if you're underinsured, that is, you have insurance, but you're still worried you can't pay, you're still 21% more likely to delay care than someone who has good insurance and isn't worrying about the bill. So being uninsured or underinsured can be lethal in this situation because people don't get the care they need. Now, sometimes people go get the care they need, but run into a lot of trouble. And this was some work that the actual labor union did at Johns Hopkins University. Johns Hopkins was a really well thought of hospital down in Baltimore. But Johns Hopkins will, if you go to Johns Hopkins, you can't pay your bill, they'll sue you and they'll garnish your wages. They'll get the court to order that your employer has to turn over part of your paycheck to Johns Hopkins, right? Well, what the union found is they looked through the records and said, well, who are the employers of these people who are getting their wages garnished by Johns Hopkins hospitals? And lo and behold, the top two employers of people getting their wages garnished by Johns Hopkins Hospital was Johns Hopkins University and Johns Hopkins Hospital itself. Okay. So they were literally garnishing the wages of their own workers for an average bill of about $1,400. So hospitals and doctors, sadly, sometimes aggressively pursue debt in ways that really frightens people off from getting care and is very punitive in terms of taking wages away from lower income people. This is some work we did and published in the JAMA Network Open, actually just 2 months ago, looking at the extent of medical debt in a national survey. About 18% of households in the United States carry medical debt. So almost 1 in 5 households, people have an outstanding medical debt. But we were able to look over time among people who newly acquired medical debt over a 3-year period. And if you took on new medical debt, you were twice as likely to become food insecure, be unable to buy nutritious food, twice as likely to be unable to pay your rent or utilities, and almost 3 times as likely to be evicted. So inability to pay for medical care, medical debt is not just embarrassing, it can force people to eat less nutritious food and even lose their housing. Obviously, things that are very, very bad for your health. All right. So meanwhile, with all this going on, the United States continues to spend more than any other nation on medical care. And at the bottom of this slide, I have graphed the United States per capita health expenditure in two colors. Yellow is the taxpayer-supported share of healthcare, and orange is the private share. And the taxpayer-supported share includes Medicare, Medicaid, VA, military, but also the insurance, the health benefits of public workers such as myself. I work for the city and state of New York right now, and they're willing to pay $10,000 toward my health insurance. That, of course, is public money as well. Though I still get my health insurance through Harvard, but my former employer. But I want you to look at where this yellow bar ends, where the taxpayer share of per capita spending in the United States ends. I mean, it turns out that the U.S. is spending more in taxpayer-financed healthcare than the total healthcare, public and private, of other wealthy nations. So we are spending, nearly $9,000 from taxes, and then we turn around and spend another $4,000 out of private sources, usually our own pockets, for healthcare. So we are paying the full cost of having national health insurance system like they have in these other countries, Germany, Switzerland, or Sweden. We're just not getting it. And then we're paying more money, and then still people can't afford care. Now, part of the explanation of this is a tremendous growth in administration. This is a growth of administrators relative to the growth in blue, managers in blue, relative to the growth of physicians in yellow. A lot of that is the insurance overhead, the money that you pay to your insurance company as premium, but never comes out as medical care. A lot of it is the high overhead costs of hospitals, which have to send bills to all these people on different insurance plans. Duke Medical Center in North Carolina is about 1,000 beds. They hire 1,600 billing clerks. Toronto General is about a third larger. They have almost 1,300 beds, and yet they have 7 billing clerks in the entire system. So the hospital costs include a lot of costs for the actual billing apparatus in the United States versus Canada, Toronto, where they can build a single payer system. Physicians have huge expenses. When I used to run a small private faculty practice, actually, we just spend a huge amount of money sending the bills. So what do they do in Canada in the single payer? They have a federal law that says you have this province, like our state, has to have a program that the federal government will send them a bunch of money, a big share of the money to run. But the program has to be universal coverage that does not impede, whether directly or indirectly, whether by charges or otherwise, reasonable access. There are no co-payments or deductibles for hospital or physician care in Canada. There needs to be portability of benefits from province to province. There needs to be coverage for all medically necessary services, as in all hospital care, all doctor care. They're in the process of implementing complete pharma care and dental care as well. A publicly administered nonprofit program. And since Canada has implemented her national health program, healthcare costs in Canada have continued to go up, but they've risen much more slowly than costs in the United States, shown here as a share of GDP devoted to healthcare in the two nations. In fact, of the total difference in spending between the US and Canada, which is about $7,000 per capita, half of that total difference is just the excess bureaucracy in the United States. Okay, so, is the care better or worse? Well, most studies show the quality of care is a little bit better in Canada. It's not a lot better, but this slide shows that it's a little bit better in terms of myocardial infarction or heart attack, that you're more likely to get catheterized if you have a STEMI and non-STEMI, are two different types of heart attacks. And the mortality in Canada is lower with both of these types of heart attacks. And there's very similar data on cancers, just a little bit better average quality in Canada than in the United States. So let's talk now about financialization and what has changed in the United States recently. And financialization sounds like kind of a made-up word, but it is actually a real word. Okay, what financialization is talking about in healthcare is we've shifted, we've inverted the means and the end. Okay, so traditionally hospitals and practitioners had to use capital, money, capital for facilities and equipment to produce medical care. So capital was the means and the ends were medical care. That was the goal. But now financial entities are using medical care in order to produce more capital. So now medical care has become the means, and producing profits, more capital, has become the end, the new goal. And, there's been a slow moving process for some time, but it's really accelerated in the past few years. So the slower moving piece of this was that investor-owned insurers and facilities like investor-owned nursing homes were the initial forms of financialization. It was literally moving very slow. But now things are moving very fast, and it's what we're going to spend the rest of the session talking about, with private equity moving in, also known as leveraged buyout. You might be more familiar with that term. Is like this financialization process on steroids. It's really rapidly making the whole healthcare system a giant financial profit-making engine. Okay, but I want to start with the role of the insurance companies because they've been at it the longest. Okay, traditional Medicare has an overhead of about 2%. Medicare Advantage plans have an overhead of about 14%, nearly 14%. And you would think, well, wow, that sounds very inefficient. How can they outcompete traditional Medicare and keep growing? And yet, let's see if that, yeah, okay. All right. And what has happened is there has been this tremendous growth. This is actually some numbers from United Healthcare, which is the nation's largest private insurance company. But it turns out when you look at the different programs as a share of their revenue, used to be they mostly sold private insurance, but now they get really most of their revenue from Medicare and Medicaid. So they are growing, and they're actually growing on the taxpayer's dime. Okay, despite very well known information, I'm just going to show you one of the studies that in fact Medicare Advantage is more expensive to the taxpayers than traditional Medicare. And Medicare, the blue part on the left, traditional Medicare spends most of its money on actual medical care and a tiny amount, that little yellow thing at the top, on overhead. Medicare Advantage spends a lot less on medical care, the blue part, but a whole lot more on administrative overhead. And consequently, it raises costs to the taxpayers by about 4%. And these are monthly numbers, so the numbers are a little confusing, but it's about 4% higher cost to the taxpayer to put people in Medicare Advantage. And the way Medicare Advantage profits has to do with something I call the 20-80 rule, which is 20% of people, usually the 20% of people who end up in the hospital this year, who got really sick this year, account for 80% of total spending. And folks at the bottom 80% don't spend very much. And what I've done here is divided the population into deciles of health spending, the bottom 10% of spending, the next 10%, the next 10%, with the highest 10% all the way on the right. And if you add together the 9th and 10th decile, it's literally 80, a little more than 80%. So it's pretty obvious if you're a private insurance company and you're getting a capitated fee or a premium, the way to make money is to get that premium and provide and recruit all those people on the left-hand side of the spending continuum. And if you by any chance end up with one of those sick people who end up in the hospital and cost you a lot of money, you get rid of them. And that's exactly what's happened under Medicare Advantage. Even with all the risk adjustment and the efforts to pay based on risk, Medicare Advantage is still successfully gaming the system and getting at least $1,200 per enrollee more than it would actually cost under traditional Medicare. Now, there are, advantages to Medicare Advantage for a lot of seniors, and certainly you get free reading glasses, you may get lower co-payments and deductibles. So there's a lot of reasons why people might, feel that's what they can afford and that's what's best for them. However, everybody knows that the trade-off here is you get a narrower network of providers, and less than 20% of psychiatrists would participate in a Medicare Advantage plan. About a third of cardiologists, less than half a psychiatrist. You all know this. If you join a Medicare Advantage plan, you've got a narrower network of providers to choose from. And often that's okay. If you have a common illness, it's probably okay. There's probably good providers in your Medicare Advantage plan if you can find them. The problem if you have a complex and difficult to treat illness like a complicated or rare cancer. And this is just some data from the Journal of Clinical Oncology. It just came out, but they compared cancer care and Medicare Advantage versus traditional Medicare. They looked at 4 process of care measures, the measures of quality, process of care measures of quality. They looked at 1 outcome measure of quality, pretty important one, deaths, okay? And all outcomes are expressed as risk ratios. So it's a little complicated, this slide. But when you look at the risk ratio, Medicare Advantage and traditional Medicare, people on Medicare Advantage were much less likely to get treated at a teaching hospital, where you really ought to go if you have a rare or complicated illness. Less likely to go to an NCI cancer center, where again, you really need to go if you've got a complicated cancer. They were less likely to go to a high volume hospital that sees a lot of cases. You may not need that for everything, but you need it for a complicated cancer. Medicare Advantage patients were more likely, above the line there, to have a treatment delay. And look what happened to mortality. The mortality was significantly higher in the Medicare Advantage patients. So that's the problem with the narrow network, that you may not be able to get your needs met if you have a complex or expensive to treat illness. Okay. Now, part of what's going on right now is we're seeing a shift in the model of care delivery. I call it the CVS Aetna model. You know, CVS owns Aetna, the health insurance company. So they own the pharmacy, they own the health insurance company, and now they own the minute clinics that are in the CVS. They also just bought Oak Street Medical, which is a chain of primary care practices. So pretty soon they're going to do everything, you know, your doctor, your pharmacy benefit manager, which are those middlemen who have helped drive up, who've contributed to driving up the cost of insulin and other drugs. Now, what is for-profit primary care and why would CVS want to buy it? Okay. For-profit primary care startups, many of them private equity, some publicly traded on Wall Street. They tend to specialize in sort of high-cut touch care where you see the doctor all the time. There's wellness benefits to recruit you, like, you know, free exercise room or something. And it focuses almost exclusively on Medicare. The primary care doctors and for-profit managed care do intensive overcoding and overdiagnosis. So they might do screening ultrasounds on the arteries in your neck, whether you really need it or not. But if they happen to see some atherosclerotic plaques in there, some cholesterol plaques, it'll raise the amount Medicare pays for that patient by about $2,800 per year, and that would represent overdiagnosis. You really shouldn't be doing that on people with no symptoms, right? The diagnosis is not likely to help the patient. There's one of them that offers a primary care physicians a $30 per visit bonus just for using upcoding software, just to enter the data into the software, right? Oak Street, which is the one CVS bought, gives their primary care doctors a scribe who's specially trained in how to upcode, to exaggerate how sick the patient is so that they can go back to Medicare and get a higher premium. And the end game of this is to sell to major insurers who use the affiliated practices to boost their profits and hide their excessive overhead. So if Aetna is making too much profit off of their insurance business, there is a limit. They're only allowed 15% overhead. But what if they have 20%? What are they going to do? Well, so that they don't have to pay a penalty, they just mush some of those profits over to another branch of their business. So it's very, very lucrative for these integrated insurance provider networks to push money around to avoid the limits on medical loss ratios and overhead. There's been a tremendous amount of upcoding, exaggeration of how sick people are. And in fact, if you look at what, the diagnostic coding on traditional Medicare, that's that white dotted line, compare what's happened with Medicare Advantage. They're now coding at a 20% higher intensity, claiming 20% more. Their patients are 20% sicker than traditional Medicare. Obviously, that isn't true. That's an exaggeration based on upcoding and overdiagnosis. Okay, and this is just looking at United Healthcare, how much money they're mushing around between their insurance wing and their provider wing. I think they call it intercorporate transfers, but anything they transfer to their for-profit doctors or for-profit medical practices or clinics, they can still, United still gets the profit, but they can exclude that from the medical loss ratio requirements and not have to refund any of it. Okay. So United Health Group, that's the biggest insurer. I told you it covers 45 million Americans, 40% of whom are Medicare Advantage or Medicaid managed care. We as the taxpayers are paying those for that. Okay, they also have a giant Optum plan. Optum Health is their healthcare provider wing. It's the largest employer of physicians in the United States with over 70,000 practitioners. Optum Insights, which is our analytic branch, which collects data on 270 million patients and then manages billings for millions of providers. And then Optum Rx, which is their pharmaceutical benefit manager, mail order pharmacy, and they fill 1.4 billion prescriptions every year. So it's one giant company, and there's no such thing as an overhead limit, because United Healthcare can just push money off to the other wings and also use the other pieces to enhance their profits. So I want to talk a little bit about private equity in the next few minutes. Some of you may have read this book called Barbarians at the Gate. As I told you, it was called Leverage Buyout at the time, but it's actually the same thing. It's exactly the same phenomenon. What does private equity do in healthcare? It changes healthcare from a social good into a financial asset. And this is Rosemary Bott's idea. It's like Lego chips that you buy and sell before you've got a hospital, after you've got a bunch of Lego chips. And using financial strategies, you can maximize your profit. And there's not any particular focus on providing healthcare services, it's financial strategies. So private equity has accelerated the financialization. It has a very short time horizon. The firm usually exits in 3 to 7 years. There's almost no regulation. There's no SEC, Securities and Exchange Commission, for transparency. They use all these financial engineering strategies, and there's many of them, but they always impose large debts on the acquired entity, e.g. the hospital gets the debt, but not the private equity firm. They decrease labor costs, they boost revenue through billing tricks and rolling up providers, aggregating providers so they can have enhanced bargaining power and get higher fees. And what turns out to be very important is, unlike longer term for-profit providers, they really don't worry about reputational risk. So if the hospital where I get my care, Mass General in Massachusetts, does something egregiously awful, they have to worry about losing their reputation if I publicize it or something. But private equity doesn't care. They're in and out of there in 3 to 7 years, and it doesn't matter to them what happens to the reputation of the hospitals they acquire. So this is how private equity firm built a Boston hospital system. Is one of the largest Catholic systems, regional Catholic systems. In 2011, Cerberus Capital bought Curitas, which was the Catholic system, from the Archdiocese for $895 million. 5 years later, they sold the hospital real estate for $1.25 billion, more than they even paid for the whole system. They gave themselves a $5 million dividend, and then the hospitals were forced to pay rent on buildings they used to own. So out of the hospital's budget, now they're paying rent. In 2016, through 2019, they bought 33 additional hospitals, mostly with debt borne by the hospitals, not the private equity firm. In 2019, they were rated the worst performing system in Massachusetts. And in 2020-21, they sold the debt-ridden chain to its doctors, because the doctors really didn't want it to go under. They sold it to the doctors, and Cerberus put another $700 million in their pocket. So now we have this hospital system that owns no property, that's deeply in debt, and actually they've damaged the quality. Okay. Similar story about when a private equity group, Carlyle Group, bought Manor Care nursing homes. It was the second largest nursing home provider in the United States. They paid $6.1 billion in a leveraged buyout, with the nursing homes responsible for $5 billion in debt. They sold off the real estate for $6.1 billion. They paid off their investors, and the nursing homes were stuck paying $472 million annually in rent, so out of the nursing home budget. They started to meet that rent. They started laying off staff, cutting costs, had soaring quality violations. And in 2018, Medicare filed for bankruptcy. The CEO left with his $117 million, and all of the investors had made money. So basically damaging the healthcare system, taking the real estate and other assets out of the healthcare system. Okay, so we have this other problem, which is our nonprofit health systems are misbehaving. Many are becoming speculative investors. Often those are a list of big nonprofits on the left, and they're going out and investing in hedge funds, billions of dollars in hedge funds, billions of dollars in private equity, billions of dollars in total investment. So even our nonprofits, who we think of as being more benign, are trying to get in on the action here as investors. Okay, so this has led us to say Medicare for all is not enough. In the past, we just said, well, all we need to do is get the government to pay for everyone in a Medicare for all program, and our problems would be solved. But the problem with Medicare, I mean, we still need Medicare for all. We definitely need Medicare for all, but we also need to regain control of ownership of hospitals, nursing homes, and return the control to the community and take it away from profit-seeking corporations. And this is something we wrote with 3 of the former presidents of Physicians for a National Health Program, saying we're going to need Medicare for all, plus we need to reform the ownership. What we're going to need is a single-payer Medicare for all. We need to ban private insurance duplicating public coverage, or the participation of Medicare Advantage and other subcontractors who take the taxpayers' money and function as a subcontractor. We need to ban for-profit ownership of providers. We need to pay hospitals and facilities global operating budgets so that they can't make profits, which they sometimes call surplus in a nonprofit setting. We need to fund capital like new buildings and equipment with government grants based on community needs. And we need to reestablish community control of our hospitals and nursing homes under federal guidelines and payment regulation. Now, is this a popular idea? Well, certainly polls continue to show that the majority of the American people support Medicare for all, even though the politicians aren't talking about it much. As recently as 2021, this was true. And similarly, polls are showing that there's a massive growth in physician support for the concept of single payer. Okay, so I'm going to stop sharing, and we've left a little time for comments. No. Okay, so comments, feedback, thoughts?
Well, Steffie, this has been wonderful. I can think of a whole lot of questions, but I think you've given us more than an hour of your time. Does anybody have any last words of thank you or whatever?
Well, thank you for the great questions, guys.
Thank you for everything you've done.
Thanks for your knowledge, and it would be great to get the recording and dig into things a little more.
Okay, it will be on our website, UUJEC.org webinars /webinars. So it'll be on in a day or so.
Bye. Good night, everyone.
Thank you.
Good night. Thanks.
Thank you.
Good night, and thank you.